I'd like to thank everybody who has come out on a weekday working night to spend 2 hours with us this evening. You are honoring us with your presence. And without further ado, we're going to get this thing kicked off right now.
Hey everybody, this is Daniel. Thank you for joining our Opioid Abatement Advisory Commission Town Hall this evening. And thank you to the members of the Commission for undertaking the difficult task of administering the distribution of the Commonwealth's portion of the opioid settlement funds. There is hardly a family anywhere in the Commonwealth that is immune to the scourge of opioids. We've lost thousands of our fellow Kentuckians and seen families and children torn apart by the grips of addiction. This evening is for each of them. For the mom who lost her son at the prime of his life, for the father who begs his daughter to get a trip, for the young girl in foster care who prays every day that her parents will get better and she will return home. Those of you here tonight know these stories well. These are the Kentuckians we are fighting for. When it comes to the opioid epidemic, no state was harder hit than Kentucky. We know that recovery will be a long process, but as Attorney General, I remain committed to the promise I made when I ran for office and will continue to fight at every turn. I hope that tonight's town hall signals to each and every Kentuckian we will always be in their corner. We will use every available tool to support the important work that is being done to treat addiction, support individuals in recovery, and further the work of opioid abatement programs. So thank you for being here, sharing your stories. Together, I am confident we can bring hope and help those struggling with opioid use disorder. Thank you, and God bless.
We're going to start introductions of commission members who are here present with you this evening from here to here.
Good evening. My name is Vaughn Purdy. I am honored to be a commissioner for the Opioid Abatement Commission. I am representing the Louisville area. Louisville, Kentucky area.
I'm going to stand up. I'm Eric Friedlander. I'm Secretary of the Kentucky Cabinet for Health and Family Services. Also honored to be serving on this commission. Thank you all.
I'm Representative Dan Bentley from Greenup County, District 98. I sponsored the bill through the House, and so if you got any questions about the bill, you can come to me. And I have a Doctor of Pharmacy degree from the University of Kentucky, which makes me the one for pharmacology. Thank you.
Good evening. My name is Van Ingram. I'm Director of the Kentucky Office of Drug Control Policy. Before that, I spent 24 years in a law enforcement career up the river here in Maysville, Kentucky, where I retired as Chief of Police and been in Frankfort for 18 years now. I'm honored to be a part of this commission. Looking forward to hearing your comments. We learn something every time we do one of these, so looking forward to learning some more tonight. Thank you.
If you are a public official in attendance this evening and wish to be recognized, please stand. We will move from the front to the back so that you can say hello to your home folks.
I'm Kenton County Sheriff Chuck Corsenborn. I'm glad to see the big turnout we've got here. We know what happened here. It's the biggest problem we've got.
Steve Henry, I'm the Judge Executive of Campbell County. I'm supposed to be able to make a few comments later, but for now I want to thank you for being here on behalf of our community.
I'm Mark Field on the Kenton County Jail.
Charlie Cleese, Mayor of Bellevue.
Missy Rittinger, Boone County Coroner.
John Cole, Mayor of Riley Heights.
Amber Constantino, Kenton County Coroner.
Jeff Essiker, Campbell County Commissioner. Brian Painter, Campbell County Commissioner.
Tom Lampy, Campbell County Commissioner.
Stacy Chaffee, the Kenton County Attorney.
Thank each of you for being here this evening. You said we got one other.
Buddy Wheat, the State Representative of the 65th District, my home district here in Kentucky.
Rachel Roberts, State Representative, 67th District, Supreme Court, right across from Campbell County.
Thank each of you for being here. It's wonderful to see such a strong turnout of local elected leadership to hear about what the community has experienced over this past 25 rough years. My name is Brian Hubbard. I grew up in the coal fields of Virginia. I've lived in Kentucky since 1997. I started practicing law in this state in the year 2000, and then practiced for 16 years, which was just about 15 years too long. The most valuable part of that experience was the wisdom that was acquired from having watched processes play out that were related to the field in which I practiced, which was workers' compensation law. I happen to represent Walmart stores statewide, literally from Pikeville to Paducah, and out of 120 counties in the state, I think there's only 10 that I've not been into. And when I wake up in the morning, I smell the inside of a Walmart store almost every day. I tell folks that I was present in practice at the detonation event of this epidemic, the point in time at which OxyContin became a commonly issued prescription for any number of conditions for which it should never have been prescribed. I practiced it, I faced it, and I watched it wreak havoc within my own caseload, which was just a minuscule microcosm of what was planned out across the state. I like to tell folks I was raptured out of private practice in 2017 and had the opportunity to then work as what they call the Deputy Commissioner for the state's Department for Income Support, overseeing the administration of the state's Social Security Disability Program. And then in the fall of that same year, I was elevated to the position of Commissioner, which came to include the administration of the state's Child Support Enforcement Program. In 2020, I had the honor of receiving an appointment to be what they call the Executive Director of the Office of Medicaid Fraud and Abuse Control within the Office of Attorney General. And since June, I have had the privilege of serving as Chair and Executive Director of this brand new Opioid Commission that you see in front of you, which is the closest thing to a government startup that you're ever going to see come into fruition and evolve before your very eyes. This evening is devoted to you, to what you've seen, to what you've lived, to what you've grieved, and to what you have and continue to have to overcome. We're going to share some information with you tonight about where this money comes from, how we got it, how it's going to be administered, and what the most recent impact of the opioid epidemic on your community is. And so without further ado, this year, the state of Kentucky, through the Office of Attorney General Daniel Cameron, settled with what we refer to as the Big Three opioid distributors, AmerisourceBergen, Cardinal Health, and McKesson, as well as one manufacturer, that being Johnson & Johnson, which did business under the name of the entity Janssen, for $478 million. House Bill 427, in which our friend Representative Bentley had a heavy hand, and is codified at KRS Chapter 15291 and 15293, provides the rules for the administration and distribution of these funds. You will see here the combined settlement totals and the payment schedule that is in place, with first payments arriving in the state in December of 22 and continuing on an annual basis through July of 2038. You will see that there is a sum that is indicated as the total to Kentucky, as well as a 50% portion. 50% of funds will go directly to local governments, that being the cities and counties. 50% will go to the Commonwealth. That 50% is the money that will be administered by this commission. Senate Bill 90 provides that $10.5 million of the state share will be spent every year from 2023 through 2027 on a behavioral health, developmental, and intellectual disabilities budget unit for a behavioral health conditional dismissal program. This program is going to essentially reverse the traditional process that we have had in place when it comes to individuals who become involved with our justice system. Rather than charging and convicting, imprisoning, and then creating an ordeal for the expungement of a record so that individuals can reclaim ownership of their lives, this program instead will be implemented in 11 counties and will utilize what is called a deflection model, where an individual will undergo a comprehensive assessment that involves both various substance use disorder identifiers as well as a battery of mental health tests to figure out whether there are any coexistent mental health disorders which affect the individual. Once that testing is administered and their needs are assessed, then they will have the opportunity to complete an individualized treatment program, which at its conclusion will see the evaporation of any charges which may have otherwise been levied. There will be no prosecution, no conviction, no incarceration, and no expungement that that person has to go through in order to get moving. All funds, whether they go to the local governments or to the commission, must be used for the purposes of opioid abatement. Local governments and recipients of commission funds must submit what they call regular certifications of compliance. This commission has the responsibility of making sure that every dime is spent in accordance with the law. And what the law requires is what the settlement agreement requires. If we don't follow what that settlement agreement calls for, then these people who caused this problem can come back and demand we repay them for our failure to follow the letter of the agreement. This commission is going to require quarterly financial reports from the counties and the cities, along with authenticating documentation, so that we can give a clear and transparent account, first, to our own people, that this money is being spent correctly and honestly, and also be able to give an account of ourselves to the settlement administrator so we don't face liability and having to give money back to the people who put us in this predicament. The commission itself was established by House Bill 427, also codified at the sections of law previously mentioned. We will oversee the state's 50% share of the settlement. The commission's composition is of 11 total members, 9 voting and 2 non-voting. Voting members serve 2-year terms after staggered initial terms. The non-voting members serve at the pleasure of the Senate President and the Speaker of the House. Those appointed by Attorney General Cameron are myself, Dr. Jason Roop, who unfortunately could not be here this evening. If you have not heard of Dr. Roop or have not had an opportunity to hear his personal life story, it is one of the most powerful testimonies as to the capacity for human beings to overcome this problem that I have ever heard in my life. And I very much regret that he had a conflict this evening, so that you don't have the opportunity in person to see him, his story, and to feel his beautiful spirit. We have here with us Van Ingram, who is the Executive Director of the Office of Drug Control Policy and very much a veteran in this fact. Vic Brown, who represents law enforcement and is the Director of the Appalachian High Intensity Drug Trafficking Area Task Force. We have Ms. Vaughn Purdy, who represents Citizens at Large from Jefferson County, and Ms. Karen Butcher, who also represents Citizens at Large. Ms. Butcher could not be here. Her relevant knowledge pertains to the death of her son to a fentanyl overdose at the age of 31 in May of 20. Other commission members are Treasurer Allison Ball, Representative Bentley, who sits here to my left, Mr. Carlos Cameron, appointed by Senate President Stivers, who happens to also work with Congressman Hal Rogers. And then Dr. Sharon Walsh, who's been appointed by the University of Kentucky's Healing Team Study and is their lead investigator. And then finally, we have CHFS Secretary, Mr. Eric Friedlander, who occasionally has Dr. Alan Bringel pinch hit for him when his schedule conflicts. What's on the horizon for 22 and 23? This is our 4th of 8 town hall meetings for this year. The next ones will be in Lexington, Louisville, Bowling Green, and Paducah. We have had our first 3 business meetings, with our 4th to occur in November. The online application process for the administration of grants formally opened and became live yesterday. Now, I just want to do a little bit of bragging, if it's all right. This commission's membership was appointed by the Attorney General in June of this year. Anybody who is acquainted with government work knows that it doesn't exactly move at grease lightning speed. But from the beginning of the composition until October 17th, the commission compiled a completed application, having reviewed those models that across the state that existed, that ranged anywhere from 2 to over 400 pages. Ours is 15. We have an organizational disclosure form which makes sure that everybody's going to be able to see who's asking for the money and who's going to get it and just exactly what they're going to be doing with it. And we aim to have the first awards made in January of next year. And I am very proud and honored to have had such a collection of expertise to help make this so far happen without a hitch. Now, this is where the rubber meets the road. These are going to be overdose death statistics that show the evolution of this process roughly over the past 10 years. And you will see that for the year 2020, Kentucky is number 3 with 49.3 drug overdose deaths per 100,000 people in our population. You see that phrase that says age-adjusted rate. What that means is that the differentials in ages among the states have been adjusted so that we are doing apples-to-apples comparisons with our other 49 states against whom we are measuring ourselves. District of Columbia is number 2, which was a huge surprise. West Virginia, number 1. You will want to pay close attention to this one. These are drug overdose deaths by year. It says 2020 at the top, but just today we added the provisional figures for 2021. They are provisional because the CDC has not yet finalized those figures. You will see a steady upward climb of total overdose deaths, tracked almost exactly by those related to opioid overdose deaths. You will see a significant spike in 2020 and 2021, which were our 2 COVID shutdown years. World War II is considered to be one of the most epic existential wars this country ever fought, second to the Civil War. We have lost more people in the United States to drug overdose deaths between 2018 and 2021 than we had total combat deaths in World War II. You look at the orange line, going back to 2012. This comprises essentially 10 consecutive calendar years. Total opioid deaths alone equal 445,913 individuals. This exceeds the total combat deaths incurred in World War I, World War II, Korea, and Vietnam combined. And all of those wars were waged over the course of approximately 17 years. And here is our state. You just take in the trend line. We have broken this down by region. And the region for purposes of this town hall includes Kenton, Boone, Campbell, Gallatin, Grant, Pendleton, Bracken, Owen, and Carroll. And you will see that the region is just slightly below the state as a whole when it comes to overall drug overdose deaths. And here are our opioid numbers. And this places the region at the same number 3 spot with the state when measured against the rest of the country. You will want to pay close attention to the evolution of color on the next 3 slides. The dark blue represents the greatest intensity of overdose and overdose death activity, with gray being relatively small and white being none. This is 2019. The area outlined in red is the region just articulated. 20. 21. Having grown up in Virginia, I am still a second home boy, though I've been here now 25 years. My perception of northern Kentucky is that its geographic placement atop the state is appropriate because it is one of the jewels in the Commonwealth's crown as measured by economy, as measured by creativity, as measured by regional unity and efficiency, and just the very dynamic nature of what is produced here by way of productive economy year in, year out, that the rest of the state depends upon to receive services throughout Kentucky that remains one of the most impoverished states in the country. The rest of us owe y'all a debt of gratitude for how you run your region. What this map demonstrates is that the opioid epidemic is not a respecter of color, of status, of class, or of bank account. If this can be ground zero, anywhere can. You will want to go to findhelpnowky.org where you can find what resources are within 50 miles of Covington. We have 26 outpatient facilities, 2 residential facilities, 0 inpatient. There are 4 within 100 miles. And medical assistance for opioid use disorder facilities, we have 22. Recovery support, there are 20 devoted to employment assistance, 17 to housing assistance, and 7 to transportation assistance. Anybody who wants to know what you've got and what you can utilize can go to findhelpnowky.org and it will give you the rundown. Without further ado, this podium is yours. We only have a couple of requests. We want those who are in recovery, those who are working toward recovery, to be first up here. If you are the family members of those folks, we want you to be next. And if you are the family members of those who no longer are with us because they are the casualties of this epidemic, we want you next. Those of us who are public officials, those of us who are service providers and wish to advise everybody as to what we have to offer, I ask that we defer to those just named first. We're going to stay here as long as it takes to hear what everybody has to say and wishes to get off of their chest. Treat this like it is your own living room. After all, your taxpayer money is paying for it. And so without further ado, we are here to hear you.
I know there's a brave soul here somewhere. There we go.
Hello, my name is William Fox. I'm a person in long-term recovery. What that means to me is I haven't seen it necessary to use a drink or a drug since October the 24th of 2017. For that, I'm grateful. I am also a senior outreach coordinator with Oxford House, Inc. Oxford House, Inc. is a nonprofit organization. We currently have 105 homes in Kentucky, 15 of which is in Boone, Kentner, Campbell County. 82.3% of our residents have struggled with opioid use disorder, and we have been around since 1975. So we have went through still in the opioid crisis. Our mission statement is try to provide a bed for everybody that needs one. You know, we are the only evidence-based recovery housing in the United States, and we have an 80% success rate if you live in one of our homes for 18 months, done by DePaul University. I would like to ask the commission to meet with us at some time, get to know who we are, what we're trying to do in our mission statement. There are some roadblocks that we run into, some challenges that we have when we open up houses, and particularly around furnishing the homes. You know, some of the furniture and the bedding could help thousands and thousands of people that have struggled with opioid use disorder. And with that, I am forever grateful. Thank you for allowing me to speak.
I need to make one other brief statement, and I'm sorry to interrupt the beginning of the flow, but I do wish to recognize Representative Kim Mosier, who just came in a short while ago. And for those of you who may not know, she sponsored a very much needed Casey's Law amendment, which passed with unanimous support. Thank you for being here this evening, Representative. It is important to also know this is a no-shame environment. This is our fourth one, and the folks in Pikeville, Ashland, and Hazard pulled no punches, and don't y'all neither.
Living room, right?
Yes, sir. Yeah.
Hi, everybody. My name is Jason Merrick. I'm a person in long-term recovery. And what that means for me is I've been able to live for 13 years now without the use of drugs and alcohol. And I've been able to be, I've been able to do things that I never thought would be possible in the service of the men, women, and children in our area throughout the Commonwealth. And it's a real honor to have a seat at the table. This is somewhere that I didn't think I'd ever get to in life. I thought it would have ended a lot sooner. So to be able to share with you some of the really heartfelt and personal barriers that got in the way of me being able to find my path and it took 20 years basically of active addiction before I could find a way into this world of recovery. And it was a lot of the stigma around it. Like, I was afraid to admit to people that I had a problem because of how they'd feel about me, because of my employment opportunities and how I would support myself, and just that shame around coming to terms with this disorder. And frankly, I didn't really even know what alcoholism was until I had it. And I thought that was, that's kind of what kept me in isolation. And then as someone entering into treatment, this wasn't the case for me, but I know there's a lot of parents out there that really want to get help, but they can't because they have their kids, and they don't know what would happen with their kids if they were to go into a residential treatment center. And so that prevents a lot of people from being able to access the care. And then there's this whole question around medicine for opioid use disorder and for other substance use disorders. So, I think for me, all I really need to know is that there's a medicine out there that could have prevented a lot of these people from dying, all the loss that we had. And I'm not a doctor, and I don't have a medical background, but I do know that there's something out there that helps people to live long enough to find their pathway into recovery, and that's all I need to know. And so instead of just we've developed this culture of tolerating medications for opioid use disorder, and we've tolerated it for a while now, but I think we need to get past that and start encouraging people to use this medicine that can save their life and keep them alive long enough to find their pathway in recovery. So we need to move past this tolerance and into encouragement of it. It's maybe not forever, it may be forever. Either way, I'm still not a doctor, and most of us in here aren't doctors, so it's not up to us how long it lasts. But and then secondly, there's another, or thirdly, or wherever I'm at here going through treatment. It was 13 months and 1 day that I stayed in a residential treatment program. 13 months and 1 day. And that was the time that it took for me to find my foundation and feel safe and comfortable in my skin, in my recovery. And it's different for everybody. This mandate, or this, however our programs are funded, doesn't really honor the individualized pathway that people need. That's what I needed, and it worked, right? Long-term treatment worked for me and countless others. And so I think we need to really take a look at this, what we're approving for periods of time, like making long-term treatment completely sustainable and fundable through our managed care organizations. And, and I know you said people in recovery first, so I'm trying to stick to that, but I also am a provider. I work for a provider, and we fight tooth and nail for every dime to keep people in treatment for a long period of time. And it's getting harder, these pre-authorizations and the, concurrent reviews are getting denied, and so keeping somebody in treatment for 6 months, which is only half of what I needed, is almost impossible. And so as a provider, we lose money because we want to do the right thing and keep people in care until they're stable. And then we get into this aftercare conversation and all the housing and the transportation and just the little things like keeping food on the table. And for these months after treatment is notoriously, there's no money for that. There's no support, not a lot out there. So somehow folding in, I don't know if it's vouchers or scholarships or whatever it is, but having something so people can make ends meet, while they're getting their life on track, they're coming out of treatment, they're coming out of jail, they're coming out, whatever the case may be, something to keep food on the table and keep a roof over their head, keep their kids fed, get them to school and back, while they're for at least 18 months, 2 years. We keep medically we talk about this being a long-term disorder that didn't just happen overnight, and we're not going to fix it overnight. We're not going to fix it in 28 days, 30 days, 2 months. People need to go through staggered levels of care, very intense down to just support, and it takes months, if not years. So if we're going to study this and understand that it's a long-term disorder, we need to treat it like that and support those programs that offer those extended 18 months, 2-year programs in inpatient, outpatient, aftercare, all of it. It needs to be folded into our support structure to pay for these things, because it's not there now. And well, I could keep going, but I mean there's employment and all kinds of other stuff down the pathway, and then reoccurrence of behaviors and criminal justice involvement and expungement. But I'm going to stop there, and I thank you again. I appreciate your time and your attention to this. I had a chance to work with a lot of you, and I hope to work with you some more. I really look forward to that. So thanks, y'all.
I'm going to have to acknowledge the northern part in the northern Kentucky. Y'all, there we go.
I'm a physician, so, all right, my name is Guy Lerner, and I'm a physician, and I am board certified in anesthesiology with specialty training in pediatrics. That was like 25 years ago. And I'm board certified in pain management, and I'm board certified in addiction, and I'm also the physician owner of Specialist MAT, and we're an OBOT, outpatient provider of Suboxone services, and we're in Elizabethtown as well as in Louisville. And you might wonder, what am I doing up here? And I have a nice relationship with the Covington area, because I have been coming up here for 8.5 years every week. I have not missed a single week, sometimes twice a week. I'm the medical director of the NKY Med Methadone Clinic on Madison Avenue that many of you know. I started there when we had about 400 patients. We grew that to about 1,800 patients. And we're down to about 1,500 because we gave 300 of those patients to the Georgetown unit down in Lexington. So that's why I'm here. I wanted to come to the community, so I drove up. I heard about the meeting today, and I said, I dropped what I wanted to do, and I said, I want to come up. So our practice in Louisville, in J-Town, Louisville, and in E-Town serves about 900 patients, unique patients every month. That generates about 1,300 medical appointments, 700 counseling appointments, and 125 case management appointments per month. And so we're very, very busy. So I just wanted to briefly add on, I think, what you were trying to explain. Why do I do what I do, or what do I see in it? And it's what's called harm reduction. I know you all know what that is. And we always try to explain to parents and patients, you know, what this drug, Suboxone or methadone, is about. And it's really just about harm reduction. If you're an addict, and I've been speaking to addicts for 8.5, 9 years now, you really don't derive much benefit from your drug of choice, to be honest, after a period of time. And I think that's somewhat lost on the community at large, is that most addicts are not getting high, they're just maintaining or getting well. Yet the ravages of it, it's really, there's 4 risks to their well-being to someone who's continually doing that. That first risk is an economic risk. Okay, if you're spending $150 to $200 a day to use, which is now fentanyl, you really can't get ahead in life. Okay, so that's the economic risk. The second risk that they encounter is what's called the time risk. Okay, from the minute they wake up to the time they go to sleep, they're always looking for product. 24/7, 365, you don't get Christmas off, you don't get New Year's or Thanksgiving off. It's unending. The third risk is the legal risk. It still is an illegal activity. And then the fourth risk is the health risk. We used to think of it as HIV, Hep C, but now it's the risk of overdose and death. So if I can give them a drug, in my case we use Suboxone, up here we use methadone, that's basically going to take those risks away and do it relatively easily. Why wouldn't I do that? Getting back to what you said, it gives us time. So even if I'm dealing with a parent who says, geez, it's just you're addicted to another thing, I go, that's right. This isn't a matter of willpower. We have something here, Suboxone, methadone, takes a little bit more careful titration that will help, and we can buy time. Okay? Is it for everybody? No. Talking to, am I capable of dealing with people who don't want MAT or don't want to go down that pathway? Of course. That's what you would expect from a qualified physician. We can handle it all. Okay, so getting back to what you said. So I just wanted to clarify that, what the importance of MAT and why I believe in it. Because what we do see is relatively quickly, we have a very safe drug, Suboxone in my case, in the practice. Methadone's a little bit, has its own risks, a little different, but we can quickly and easily demonstrate to patients, hey, this stuff works, and it does. Okay, so why am I here? What did I want to convey to the committee here? What's my biggest issue? It's what we tell our patients all the time, show up. If you show up, you're going to get better. We deal with people, we draw from all over the region. We have 2 offices. We draw from up here, for crying out loud. Why do we draw from up here? Because we provide so many services for our patients. We're providing the MAT services. We're doing what everybody else, no one else is doing. We're providing the psych services. Mental health. We do the counseling, case management. We're providing services for alcohol use disorder. We're providing services, because I have the expertise, for palliative care for patients, which basically means they have 6 months left to live and might have some sort of use disorder. People don't want to touch these people. The hospitals, the palliative care doctors, they don't want to deal with these patients, so they send them to me. Okay? So why did I want to come up here and get in front? One, because I've been coming up here every week for 8.5 years. Seriously, I haven't missed a day. And if I'm out of town, I'm usually on telemedicine with them. And sometimes I've been coming twice a week. So this week will be twice a week. It's attendance. It's just showing up. That's my biggest issue. If I can get patients to show up, and we have patients coming in our E-Town office, all the way from Paducah down to Bowling Green over to Campbellsville. In the Louisville office, it's all the way north here to Florence. It's access to care. I know you hear about it, but there's just so many things about the access to care. I'll just give you an example here. We're trying to get an office up here. You know how difficult it is for me to get an office up here? You know how many phone calls? I got to call the county commission. We try to get an office in, what's the county? Boone County. First thing I do, we go find the place, call them up. Can I go here? Well, we'll get back. Write us a letter. We'll get back to you. Wrote them a letter. They get back to us. Sorry, we don't allow outpatient opioid treatment of patients with opioid addiction. So I thought I'd be snarky and write them a letter back and saying, well, I decided to open a used car lot. Would that work for you? For individuals who only have alcohol and opioid addiction. But I didn't. So it's just access to care, things of that nature. Transportation. That's my biggest thing. Attendance. And it's gotten worse. Why? Because of the gas crisis. Okay? If I can get people to show up, they will get the medicine, and they'll generally do fairly well. It's all the other stuff, the wraparound services that you had talked about. Those are our issues. But we can't provide those issues if patients aren't in our office. And so put a big A there, attendance, access to care. Other hurdles we face for anybody in the outpatient world, pharmacy. We struggle with just dealing with the pharmacies. As a provider who is providing multiple services, it's just unending on how difficult it is for our patients just to obtain the drugs and the medications. So if we're using a gabapentin, which we get it, okay, it's a Schedule 5, but if we're using it for anxiety, neuropathy, which a lot of patients have had because maybe they had accidents and that's how they got hooked on the opiates and stuff like that, and they've had multiple surgeries and yada, da, 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 right? If we want to use gabapentin and we don't want them to go, and they're having trouble going to a family doctor or a neurologist or a pain doctor, which is not going to happen, they come to us. But it just creates so many barriers when they go to the pharmacy, things of this nature, very simple stuff. Transportation, other hurdles, access to care. Just this week alone, we had one of our case managers get a job for a gentleman, a good paying job, sound like a politician, a good paying job. And it was a forklift operator. And he got denied the job because he was on Suboxone. Stable guy, good compliance with the clinic. We worked hard to get him the job. This was a job he previously had held, and it got denied because they were applying, which we think is some DOT, Department of Transportation rules, to whether he could safely do this job. And I picked up the phone, called the referring physician or the physician who made that decision. I said, how do you feel about insulin? Okay, because the medical data would suggest that people who are taking opiates chronically, whether they're methadone, Suboxone, hydrocodone, are probably do better overall, like, with testing and, skills, and there's no deficits. If you're on a medication chronically, you're fine to do it. Yet the fact that it was Suboxone, it was crushing to all of us because we worked really hard to get this guy a job. So these are hurdles and just access to what we want to do. All right, or what we might call the stigma of care. My big idea. Here's my big idea. I've been doing this a fair number of years at what I think is a relatively high level. We have a relationship with one of the larger recovery facilities here in the state where we put their patients on maintenance therapy in treatment. We've been doing that since 2017. by us going to where the patients were at, we were able to reduce that facility's AMA rate, again, leaving against medical advice on a 30-day stay, inpatient stay, from 40% to less than 5%, because we put them on maintenance therapy. 60 to 90, greater than 60% of their patients are staying more than 60 to 90 days. Why? Because we put these people on maintenance therapy, we get them to the right dose, and then they have a place to go, getting back to what you said about coordinating care, and just sort of, they know they're going to come to us. Okay? So based on this notion of meeting patients where they're, here's the big idea. I approached the major hospitals in the Louisville area 18 months ago, and I did say this, and they probably hated me for it. I said it's ethically and morally wrong to allow probably 2,000 ambulance rides a year to show up at your hospital and to rinse, wash, repeat with those individuals, i.e. they bring them in. 3 hours later, they're back out on the street to do what? To do the same things. These are overdoses, right? Overdose, they're non-fatal overdoses. And there's probably about 2,000 of these. I knew there's about 400 at the Audubon Hospital in Louisville, so through the Norton Hospital, so I'm assuming there's probably about 800 across their system. And you take the other couple hospitals, so we'll say conservatively 200. I didn't really get a number, but I guess got that one number. And I said, we will show up. I will pay somebody to show up in your hospital based on this notion of we have to meet patients where they're at. We will show up, put these people on maintenance therapy, and then say, hey, it's just not good enough to hand them a card anymore. That's what I was trying to tell these people. You just can't hand them a card and say, hey, go see Dr. Lerner over at the clinic. You know what happens to that card? Nothing. It gets thrown away. It never gets acted upon. So that's what we wanted to do. What do you think happened? Nothing. Zero. So I'm excited about the commission because I kind of look at this game as there's really 4 players in the game. There's the providers. That's me. There's government. There are the payers. And the hospitals. Somebody's got to, it's a forcing function. Somebody's got to act and make it happen. There's precedent for this, as I found out over time. So what have I done? We've actually gotten into the hospitals. That's how we started doing palliative care for them. We now go to the hospital for the Norton Hospital. We show up on their floors. We do inpatient consults. We're taking a little bite of the apple. But there's this bigger picture out there, right? What I said. There's 2,000. This is just in Louisville. I'm sure it's up here. It's worse, right? As you pointed out. So I think there's a better way. There's precedents. What I've learned is in Miami-Dade, Florida, they have a program. That's exactly what they're doing. I've come to learn, where all the ambulances go to one hospital. They have social workers who show up. In this case, we were going to put a nurse practitioner on there. And what do? They give them 6 weeks of vouchers, Uber vouchers. They put them on Suboxone, and they give these people 6 weeks of Uber vouchers to go to clinics with a peer support. So there is a will. That's my big thing. That's a huge thing. But it's doable. It's being done. But I think you have to, like I said, go where the patients are at.
Thank you.
Yep. Last thing, little idea. Travel vouchers would be great. Somebody mentioned vouchers. Like I said, getting back to attendance. We really struggle. We, in our own clinic, we see anywhere from 70 to 85 patients a day across both locations. We have we'll schedule 100, 110. We have about 20 to 25% no-show rate. Most of it's probably just transportation related, we think. We don't know for sure, but
Dr. Lerner, if you'd like to talk with us individually about the nature of your practice and its challenges, we'd be happy to see you at the conclusion of this town hall. And thank you for sharing your perspective.
Last thing is innovation. One of the things I'm most excited about, and just to let you know that, I mean, there are people out there doing things and innovating. What we do is, we just started doing this. We're
90 seconds.
You got it.
90 seconds.
I get you. But I think this is worthwhile, all right? Is we treat patients dual diagnosis. So we have 80% of all IV drug users have Hep C. Each one of those users with Hep C will infect up to 20 people in their lifetime. It's a major problem here in Kentucky. We've worked with a provider where not only are we seeing the patients for their opioid use disorder in our office, we also telemed that provider, and we do all the work. And all we do is we tell the hepatology doctor, here, you just get on the computer, we'll bring you in. So we're treating two things at once with one appointment. So with that, and those things like that, I think are great idea, great public health, innovation, and so hopefully things like that will spark others to think that way. Thanks.
Thank you. Thank you. Thank you. We're going to go to the next speaker. Thank you very much, Dr. Lerner. You got it. Thank you.
Good evening. My name is Tom Spicer. I'm also a person in long-term recovery. 9.5 years clean. Sometimes I just have to say that because it's still hard to believe. You know, I was at a place in my addiction where I welcomed death every day because I couldn't find a way out. I couldn't muster up to ask for help, you know, and that's what it finally took. And I started out on Oxycontin, not from prescription, from illicit Oxycontin when I was in college. You know, I was enrolled in college, getting good grades, and, you know, just like to party. And and I didn't do that with the intention of realizing I was going to destroy my life and potentially die. And addiction, it's progressive and it's fatal, you know. And it's chronic, which means like this is something, I believe in a disease model. I believe this is something I'm going to have to deal with for the rest of my life. It's like any other type of mental illness. And I treat that illness today. I take my recovery serious because my life depends on it, you know. And through this journey, you know, I found a career actually, like I wasn't even expecting it. And I told myself, I was like, I'm never going to work in recovery because it's like a cliche of a lot of people I see in the program I work. And I started working for this organization a little over 2 years ago. It's a Recovery Community Center in Newport, Kentucky, the Pier. And it's beautiful because I can tell you when I was in active addiction, I could never get honest with a therapist because I already knew that they had no idea what I was going through, you know, because they didn't have that, they couldn't think how I thought. And so I could never get help that way. It didn't matter how many times I got arrested, how many times I went across the bridge to go cop dope and I was crying. None of that mattered, right? It didn't matter like how bad I knew I was hurting my mom and she, you know, all those countless hours of sleep I couldn't pay back. But like something had to happen inside of me where the pain got great enough, you know. I had all kind of people wanting it for me, you know, and I wanted it myself for a long time. And so it's you know, I just wanted to say this, you know, for anybody that knows people that are struggling, it's not a moral deficiency, it's a disease, you know. So like what I get to do today is help people. I get to, you know, like peer support is essentially like telling our story to give people hope. And It's a beautiful thing, and I think that, you know, as a community, we all need to work together. You know, we need to collaborate together. Van, were you talking about like recovery-ready communities? And like, that's what I envision for Northern Kentucky. That's what I envision for all of Kentucky. But you know, we have a lot of resources in place compared to other parts of Kentucky, so we're already blessed in that aspect. And I think that we can just make things just that much better by working together.
Hi, Commissioners. Thank you so much for the opportunity. My name is Kim Webb. I'm the Executive Director at the Emergency Shelter of Northern Kentucky. The Emergency Shelter of Northern Kentucky is the largest immediate low barrier entrance shelter in our community. This past winter from November to March, we sheltered 682 individuals, provided over 10,000 nights of sheltering. We just recently moved in February to our brand new state-of-the-art facility. We are committed to being privately funded. We have been committed to privately funded because HUD does not prioritize emergency sheltering, especially the immediate entrance night-by-night shelter that we do in our community. If you can walk in on your own 2 feet at the Emergency Shelter of Northern Kentucky, we're going to shelter you. When I look at across this room at all of our amazing partners that do the work, we are often the first door and the first bed to allow people to sleep safely off of the street when they can't shelter anywhere else. We build relationships for them, and then when they're ready, we connect them to our amazing partners in the system. Our new facility allows us to probably shelter and provide up to 25,000 bed nights this year. We have a daytime navigation and engagement center, the first of its kind in Northern Kentucky, that allows community partners to come on site in the building to meet our partners, our guests. We call them our guests when they're in the building. We also provide Northern Kentucky's only self-service shower and laundry program during the day to allow individuals, whether they're in active addiction or facing housing instability, to come in if they're unwilling to shelter for a variety of reasons, if they do not feel safe, if they have a partner, if they have a pet. I also employ staff with lived experience. I employ peer support specialists because they have been in the trenches. They know how hard this is. As an employer, it is challenging but very rewarding to employ these individuals, but often they are stuck themselves, not being able to earn enough money and lose their benefits. My ask of you as a commission is to recognize that emergency shelters across our state often adults have the ability to use our address as their own in the state of Kentucky. What is alarming to me is I grew up in Cleveland, don't hold it against me, although go Guardians, is the fact that our state requires an animal shelter that is taxpayer funded in all 120 counties. There is no statutes for human beings. When you talk about the front line, work that happens, you have to meet people where they're at and continue to support them when they're on their journey until they're ready for treatment. There is nothing we can do other than to be present with them and allow them to continue with this disease, and we continue to support them, care for them, love them, and care for them when no one else in our community will and their families are unable. But when they're ready, they are ready. And we connect them to sober living, to all of our treatment facilities. We actually, as part of the navigation center in our new facility, we have an on-site evening health care that meets the needs of our guests. This is a partnership with UK College of Medicine students that are on the Northern Kentucky branch to meet with attendings and residents. We also have contract and grant funds to provide an APRN that do this. I would love to be able to provide mat treatment in our building. I would love to see this commission focus on emergency sheltering that is low barrier and immediate, and recognize the agencies that are doing this work outside of HUD, because our state is not prioritizing on this level for the balance of state emergency sheltering funds. Thank you.
My name is Bobby Acker. I'm a person in long-term recovery. My sober clean date is February 21st of 2016. Just kind of a little backstory on me. I was raised in a middle-class home. I was raised with morals. I knew what right from wrong is. My drug of choice is actually opiates. I got hooked on opiates. It evolved into IV drug use, which evolved into heroin. The way that my life looked like before I got sober, I was in and out of jail. I was homeless. I had lost everything. I'd lost all friends, family. The last person in my corner was my mother, and she was done with me. And that's kind of when, that is when I kind of made a change. I remember sitting in court. There were labels being thrown around from the community: junkie, menace to society. I sit in court in front of the judge. The probation officer actually said, "Mr. Acker needs to go to prison. He's a menace to society. There's no hope for him." And luckily, the judge did not deem that appropriate for this situation. I was able to get into treatment. I started working with people, therapists, peer support. My whole shift, demeanor change. Instead of looking at myself as a bad person, I started looking at myself as a sick person, getting better. And I'm forever grateful for those people early in recovery who showed me that. I was able to do family therapy to work through some stuff with my mother. I actually got a phone call from her on the way up here. She was calling just to check on me, tell me she loved me. That was not the case before I got sober. I own a home in Georgetown now. And going from homeless to that, I'm in a healthy relationship. I'm probably in a relationship where I'm going to get married. I never thought that was going to happen. I have 2 dogs. I'm a male role model to my girlfriend's son, who we're currently have enrolled in college. I'm a taxpayer. I have a car. I have insurance on everything. That's what recovery can do, right? 6.5 years ago, I would have never thought that this life was possible. I was kind of so far down in the gutter that I thought it was hopeless. And now I've been blessed with the opportunity to work in recovery. I get to work with people who have kind of hit that bottom where I was at, and I get to be that hope shot for them. I get to explain to them, like, I was exactly where you were at, and this is what my life looks like today. There is hope. So I work at a place called Roaring Brook Recovery. We're a very comprehensive treatment facility. We do things, we do therapy, we do a lot of trauma PTSD work. There's not a lot of people who enter into treatment that have not gone through PTSD or trauma. So we hit that component really hard. We're also 12-step based, abstinence based. We do provide MAT also. Nurse practitioner on staff. We have peer support, case management, kind of the full curriculum of care, right? We also provide some sober living. We're running into a lot of the same issues though, right? We had been partnering with some sober living houses. Those have started doing in-house IOP. There's just no beds available right now. So we're looking into getting some new houses and some things. I mean, we're getting a lot of calls from people who have no place to go, right? And now we don't have any options to put them in bed. So we're trying to make some changes in that area, try to acquire some houses so that we can make a difference in that area. But yeah, I love what I do today. I get to wake up and I enjoy, I get really excited driving to work, right? So anyways, I just wanted to come up and share my story. That's all I got.
Hi, I am Steve Pendry. I'm the Judge Executive in Campbell County. And there is a truth available to all Americans that if you turn on any news show, you're going to start to think nobody believes in any longer. And that would be that collaboration, cooperation, consensus building those things are tremendous force multipliers and really the way we used to solve our problems and should in the future. I want to suggest to the committee that that's how we do things in Northern Kentucky. I am one judge executive from the 3 northernmost counties. I'd like to think that I'm here because I put the best foot forward for our community, but an alternative interpretation would be Gary Moore and Chris Knockelman are not in town tonight. So I like the collaboration message. I hope you take that in. When years ago, heroin being cyclical was rearing its ugly head a little more dramatically, and we were hearing from our police and our partners that treat folks that there was a calamity underway. This community came together, didn't just marshal its resources, pool its resources. There were hundreds of people in a number of large gatherings that not only compared notes on our strengths and weaknesses, but laid plans together as to how we could do better. And one result of that was the appointment by the 3 county fiscal courts of a local Office of Drug Control Policy. I think everybody around the state has heard of that in connection with the state Office of Drug Control Policy. We have one here. Kim Moser was a leading exponent of this course of action and the first director, if I'm not mistaken, of that organization. And I have with me tonight the current leader of that group, the mission of which is to coordinate the activities of all the other partners and try to keep us on schedule and working according to the plan we made and built by consensus. So I want to introduce Amanda Peters to take the ball from here.
First, I want to thank you guys for coming up to Northern Kentucky, being so open with the process, engaging folks through the subcommittees and allowing folks to come to Frankfort, and the commissioners who have answered questions, because we have many. And as you can see in Northern Kentucky, we have a lot of feedback. So I want to provide some data of what we look like in Northern Kentucky. So in the last fiscal year of 20, we had 189 deaths from overdose, and this is from Boone, Kenton, and Campbell. The next year, we had 150. So as we had the first year in several years that Boone, Kenton, and Campbell were not in the top 5 for any overdoses for the state. So we're optimistic. We know that we see some of those trends as for methamphetamines coming into the region. So I'm grateful for the opiate money, but I want to make sure that we're addressing addiction. And we're seeing alcohol rates climb and climb every day. So we need to look at polysubstance use. We are also deploying out hundreds and thousands units of Narcan. And so that is great, but one of the unintended consequences is that we miss that intercept point. We can't get to that intervention. So we have folks that are administering Narcan, which we want to save that life. It is harm reduction. It buys us that time, but we're not able to reach them. So we're getting more creative. And right now, our biggest barrier to treatment and recovery is stigma. So I have a call to everyone in the room. What are we doing in our circles, in our churches, in our jobs, in our committees to talk about this? Because this is affecting everyone throughout the state and our region. From our population, we currently have about 9,000 to 10,000 people in active addiction every day in Northern Kentucky. There's probably another 10,000 that are seeking recovery and recovery efforts here in Northern Kentucky, as well as treatment. It's 20,000 people in active addiction or seeking recovery, and those are not counting the folks that already have diagnosed SUDs. With that, we know that almost 80 to 85% of folks in active addiction are working. These are not folks that are on the outline, they are working. And so the job is the last piece that loses when people are in crisis. So we need to have strategies that we're going to work with our employers. We still have a lot of stigma to get people employed. So we need incentives from the state to pull these folks back into employment. This is a workforce strategy that could work across the state as well as in Northern Kentucky. We need housing resources. We know that we cannot house our people. And with housing, we need regulations, and we need credentialing and accreditation for our sober living. We're very excited about SB 90 coming, but with the employment and the housing, we're going to put these people in very, very bad situations because we're going to fill up our good housing, and then with the requirement, we're going to put them in not so great housing. Recovery housing is not all the same, and we need incentives for them, and we need help with KDAR. We have incentives to help them, and I don't know if Alicia's going to speak tonight to speak about reentry efforts, but as we're getting folks and using the state assistance, we have recovery housing that will get paid up front up to 6 weeks, and if somebody relapses, has a reoccurrence, they leave the housing and the facility keeps that money. So whether it's 1 week or 2 weeks, we have folks that are homeless for 4, 6 weeks before they can get into housing, hoping that there's a bed. So housing is a huge issue. From our office, we do coordinate regional planning. We are wrapping up our 3-year plan. We've been able to look at the continuum of prevention, harm reduction, treatment, recovery, and reentry. And with that, we can identify gaps in the service, in our service and care continuum. One of the things that we were able to do with my office was we created our own local helpline. So we've been existed inside the services here for about 3 years, and we've taken close to 9,000 calls. Last calendar year, I took half as many calls as the state with 4 people. Sometimes I'm answering the phone if somebody's sick. So we are knocking down those barriers, and we don't just give out phone numbers. We are making that warm handoff to our treatment facilities. And we couldn't do it without our partners, because we don't do the direct service, we do the link. Transitions, St. Elizabeth Hospital and Journeys. I know North Key is here. People that I have on text, that I ask for data, ask what we're doing, how can we make it better? We are full of passion, we are overworked, we are under-resourced, and it is affecting every community system that we have. We also developed an Uber Health program because we know that's one of the gaps. So right now, for the first quarter of this fiscal year, I've gone through half of my money for the year. We're looking at grants, we're looking at different ways. And so our average ride is about $25. So as we're talking to get people to treatment, I can't transport to our methadone clinics. We had a small grant from our Northern Kentucky ASAP board that we're grateful for, and we were able to push that out and get more people to treatment, but that was short-term for 2 months. So now people are calling for resources, and I can't take them because we can't fund them every day. So we're also using that to get people from our treatment facilities to our behavioral health. So now our helpline and Uber Health program is addressing system problems. I got all these zoning laws, EMS can't go here, our people can't transport, and so we're solving system problems through this nonprofit government arm and funding that's coming from the fiscal courts that have already shouldered a lot of this burden. The other thing I want to mention is some of our data, and more of our data. So currently we're seeing 4.4 non-fatal overdoses that are being called into dispatch every day. This is inconclusive data. It's not the folks showing up at the emergency department. It's not the runs at our EMS where police don't show up. And it's also not where Narcan is being self-administered. So we know those numbers are higher, and we're very nervous about the numbers that are crawling for the next year. So we're keeping our eye on that. We're cautiously optimistic. That is my professional hat. My personal hat is I've dealt with this disease with my parents for the last 39 years. Rock bottom for our people is death. I've already lost one parent to this disease and mental health. I didn't think I'd get emotional, so I'm sorry. I see a lot of these folks in meetings. My mom fights every day for recovery. She's got 60 days sober today, last week. And I have had to work with my partners, and I know we couldn't have done it without Sun Behavioral Health and Transitions. And I'm a person that knows the system. I text these folks to get them in. I work with them every day. I'm texting my friends, what do you think we need? What do you think I could do? Can I show up? And then I'm stuck with HIPAA because I can't get information. Our family members cannot get information when we need it, and we don't know how to help them best. So I just wanted to share that and some of the data that we're seeing in Northern Kentucky. We need help with housing, we need help with transportation, and stigma is still our biggest barrier. Thank you.
Hi, I'm Adam Rowland. I work with CH&K Behavioral Health. Our outpatient offices are right over on 5th Street in Philadelphia. I won't take up too much of your time. I just wanted to tell a couple of stories that I think reflect a couple of the issues that we deal with when we're talking about treating mental illness, co-occurring substance use disorders. The first one was something that I dealt with just today, and it's access to treatment. We had a 16-year-old boy who came in, was assessed, evaluated to have a substance use disorder with co-occurring mental illness, in this case depression. This boy lives in Boone County, out just south of Florence. And in evaluating this individual, we worked with the parent to try and see what resources they could provide. We recognized, because of the severity of the illness, that individual therapy was not going to be enough. So that required more intensive treatment, more frequent treatment throughout the week. The problem is the proximity. The proximity, even just to south of Florence, is too far for this parent to travel to. This parent works until 6 p.m. Access to treatment is a major issue, even in just a few miles. I was also talking this morning with an individual who works at the Grant County school system, and I grew up on the Grant County-Owen County line, so I'm keenly aware of the region. I asked him, hey, where do you send your kids who need just more than just individual school-based therapy? Where do you send your kids when they're dealing with substance use issues in the school? We don't have anybody. That was the answer. Now, of course, there's telehealth options available, but those aren't for everybody. A lot of teens can't participate in telehealth the way that adults might be able to. So I just wanted to bring that individual, that 16-year-old up, because I'm not going to speak in absolutes. Maybe there's a provider here that can help this person a little more close to home with this intensive service, but I don't know who it is. And I've been doing this for 7 years, working in adult substance use and working with teens and younger kids with mental health issues. The other issue that I wanted to bring up is cost of treatment. So I did a quick Google search today, and the National Institute of Health talked about the different reasons why people with co-occurring disorders might not seek treatment. And two of the top reasons are they don't know where to get it, and they can't afford the treatment. So we operate a partial hospitalization program, 20 hours a week of group individual services for individuals with primary mental health disorders. So these are individuals that have really severe symptoms to the point where the alternative is hospitalization or something like that. So we're trying to avoid that level of intervention. This individual had a co-occurring substance use disorder, but they had commercial insurance with a deductible of $6,000. I don't know, I didn't know where to tell this person to turn, to have to spend, upwards of $6,000 on a treatment that, in all likelihood, if they didn't get that, the substance use disorder was going to get more severe. There's going to be more health impacts. They were going to be hospitalized because of this. So those are just a couple of stories of a couple of people that really, I think, need to be addressed. And number one is access to treatment. So how close in proximity are we in relationship to these more intensive treatments, particularly with adolescents? So I know out in Grant County, I had a couple of phone calls with court-designated workers from more rural counties in southwestern portion of northern Kentucky. They don't have a place to turn except for these telehealth services, which oftentimes even those in and of themselves have wait lists of 2-3 months at a time. And if you need intensive outpatient treatment, you need it today, not in 3 months. Otherwise, risk of hospitalization and all those things. And the other thing, of course, is cost. So we're able to work with families and individuals on a lot of these things. We're certainly not going to give up at CH&K, at least with these two individuals, but I think this is a more global issue that needs to be addressed. So those are just a couple of things that I wanted to bring to y'all's attention. Thank you.
Sorry, Bonnie. I hadn't seen Bonnie in years. Hi, everybody. My name's Meredith. I happily worked for Kentucky's Child Protective Services for about 10 years. I'm here now as, I guess, just a concerned citizen, right? But I've heard people say things which have really resonated with me. So Jason and I were talking about this meeting this morning, and so I had the whole day to brainstorm ideas, and it went from well, I have a little suggestion or two to now I'm talking to my coworkers and what can we dream about? What can we do? Look at all this money, right? So I have a list. I've compiled it, been clutching it up here, shaking like a leaf, thinking about it. So we'll start small. People have already mentioned wraparound services, but really case managers to support people's transition from treatment to safe, sober housing, right? Safe, sober, quality housing for people who are leaving treatment is going to be important. The Oxford House guy, wherever you are, We loved using Oxford House as a resource for parents that we worked with here in Northern Kentucky. But I don't mean just within the first 6 weeks of getting out of treatment. It's so much more than that. It can take so much more time than that. And people really need that support. Somebody talked about, it was Amanda, talked about navigating these complex systems, and it's hard for even people like us who do this professionally, right? So then we're asking people who are in very early recovery to navigate this complex stuff that sometimes we don't even know how to do, right? So how can we use peers? There was a guy from the peer here. How can we really use peers to help people navigate these systems, these complex systems that even professionals can't do? That's just the first one. Whew. Let's see. So more treatment options that allow parents to bring their kids with them to treatment. How can we lessen separation of parents and their children? Removals cause a lot of trauma. People don't think about that. We think kids are going into foster care, great. They're going into loving homes and people will take care of them, but we're really causing more trauma to people who don't need that. This one's double-sided. When I say more options for parents, I mean moms and dads. When we think about this, so often the gut instinct is, yes, we need more options for moms to take their kids with them. They have another parent. How can we help other dads, right, supporting fathers in their role as fathers to help care for their children? I for one, don't know of options where dads can take their kids to treatment with them. Now, I know of some for moms and their children. They're few and far between. There aren't enough of them. That's what we know. On the tail end of that, options for sober living for parents and their children, right? We need evidence-based programming for fathers. We have a lot of evidence-based programming for families, for moms, but specific stuff to dads, right? Let's see. Somebody was already talking about harm reduction, but that was on the list, expanding harm reduction. I think when I was thinking about this earlier, when I've heard people talk today, I'm a Kenton Countyan, but the region is bigger than just Boone, Kenton, and Campbell. In my CPS career, I spent 5 years doing investigations in Carroll County. Carroll County's like a desert. We didn't have anywhere to send people. Adam, this was, when you talked, this was what I was thinking of. You talked about living on the Grant Owen line. Well, that's just out in the middle of nowhere, you know? It takes time to drive to places to get treatment. And even in Carroll County, I would tell people all the time, well, if you can get to Florence, well, you may as well ask people to throw in the towel right then because it's so complicated. So there are a lot of great resources up here, but we need more in the lower part of this region in general. We need expanded access to detox. When I worked up here, working for CPS, working with people with substance use disorders, getting a detox bed at Transitions, hard to come by, right? Transitions was a great partner. They just didn't have enough detox beds. We could expand sobriety treatment and recovery teams in the state. I know it sounds a little weird because I'm up here wearing a START shirt, but it's a great resource. It's a great resource for parents, for families who are involved with child welfare to have in their corner a team where they have a worker who's specially trained, where they have a family mentor who is a peer recovery support person to work with them to help navigate those systems that we talked about earlier. Let's see, the woman who works with the unhoused population. So what was on the list of dreams? More funding, right, for resources for outreach to encampments, to panhandlers. Like, how can we reach out to that population, bring them in, get them the help that they need on an ongoing basis? We know it's not a one and done thing. We need more permanent housing options. I don't know. I mean, I look at real estate listings at night for fun. Seems like a weird hobby, but here we are. And houses are expensive. And so rent is even worse. I often question, if I didn't buy my house 7 years ago with my husband, would I be able to afford rent right now? My coworker lives in LA, her rent is $300 more a month. LA and Northern Kentucky, we are not the same, but why are our rents the same? We need to support and expand contingency management. We know we've got the opioid settlement funds, but that's moved on to stimulant use disorders. We see that all over the place. Use of cocaine, use of methamphetamine. Contingency management is an evidence-based approach to help people with those diagnoses. Peers, we already talked about the value of peers. Okay, this is where we got to the real big dreams part. Would it be possible to have a scholarship fund for people who are in recovery? We know right now there's a workforce shortage. It's especially affecting helping professions. Could there be a scholarship fund as an avenue for people who are working in treatment, who are working in peer recovery support to get their education and to work in a helping profession, if that's what they want to do? On that, we have people who need criminal records expunged, right? We know people who are doing things that they didn't intend on doing when they were in active addiction. They've got criminal backgrounds to show for it now. Would there be programming available to give legal advice or scholarship funding for, I feel like that's a pretty lengthy process, right? I know somebody who's going through it, to have an attorney or somebody to help you fill out paperwork to get your record expunged so that you can do the thing you wanted to do, like nursing, for example, or work in social work. I know several people who haven't been able to do that because of their records. And then expansion of QRT and Casey's Law expansion. Of course, these were all on the list of dreams, right? So that is it. Thank you all.
Ma'am, you've been sitting for a minute.
Oh, that's okay.
Oh, no. Come on.
Oh, that's fine. If you are family members, I'd rather, please go. No, I'm Bonnie Hedrick from St. Elizabeth Healthcare, and what I wanted to share with the commission, thank you for coming up to Northern Kentucky to hear from us. I've given you our annual report for 2021, which just tells you a little bit about some of the services we have been creating across our system since 2013, actually, when we first got together, Dan. So, but I want to start with, there are three things I want to cover with you. And the first thing is I want to speak for the 51,000 people that we know are in our primary care offices who have a primary or secondary diagnosis of substance use disorder. And connected to those 51,000 people are families and children. We are now seeing the result of some of the living and growing up in a household with toxicity. We read it in the research, but we can see it firsthand now in reports coming out of Campbell County, for example, and some of the problems they're having with children who are so grieved they are angry. So yes, I want to speak for those individuals, and more services we can get for them, fantastic. The second thing I want to do is give you a concrete example of collaboration, cooperation, and everything that Judge Pendry was talking about. In 2019, we pulled together, St. Elizabeth Healthcare is the convener of a collaboration that is working. And for the people on the panel, you will find the data related to some of the outcomes related to that project called the Lift Up Project that are specific outcomes for the individuals that are involved in it. But we came together, St. Elizabeth convened the group with St. Elizabeth Physicians Journey Recovery Center, Life Learning Center, and the Brighton Center Kentucky Career Center, and I cannot forget the Workforce Investment Board. We are working to change recovery outcomes for people with substance use disorder. And St. Elizabeth Physicians, St. Elizabeth Healthcare cannot do that alone. We can only provide some treatment, some kinds of treatment that are appropriate for some people. And we work with and we try to find those places where when we find participants who need specialized kinds of treatment, we try to get them there. That's the treatment piece of it, but that's only about 20% of health and well-being for any individual. myself and people with substance use disorder too. So the other 80% has to be done working collaboratively with community partners who can help us address those social determinants of health, those barriers to treatment. And when we do that, we are achieving better outcomes. So I would encourage the Commission to look at proposals from communities that really show that kind of community cooperation, because that's what's going to make a difference. The last thing I want to share with you is what St. Elizabeth has done in the past and where we're going in the future. We do have an inpatient facility for people requiring IV antibiotic care, and we've started, and also substance use. It's called 2A in our Edgewood Hospital, and they stay there about 30 days. While they are there, Journey Recovery Center staff people and others from the community are helping to start their recovery process while they're there. That's just one of the things we have been doing. We have been working across all of our departments internally because collaboration needs to occur there as well. And oftentimes those departments were working in their own little silos. And we had to get them to work together and collaborate together in order to make a system of care for our patients with substance use disorder. Where we are going in the future is to go into those areas. The person who was talking about Owen and rural care, Grant County, we know that access to treatment is difficult for people in those areas. We are working on a mobile unit to go into those areas with medication-assisted treatment and with our partners like Life Learning Center to bring the full spectrum of recovery support with us. Not just treatment, but the full spectrum. And we also are going to work with other community partners in creating a kind of, this is a dream. It is just a dream. We're talking about dreams. You talk about dreams, I can too. So we need some kind of crisis intervention team or it's called, we've tried QRTs, but we need something more. People are coming into our emergency department in crisis. We have a bridge program that's getting them connected to treatment, and it is more than a piece of paper referred to them. It is more than that, I can assure you. And but it also needs even more. And we are in St. Elizabeth Healthcare, we are in a process of continually improving our system of care, and we are standing ready with all of our community partners to do the same thing for Northern Kentucky. And thank you for listening to us.
Okay, I told Shamika that I was going to go first because she always talks before me and I can never follow her up. So my name is Jennifer. I am a person who struggled with opiate use for 20 years. I get really nervous when I speak in front of people, so give me a second, sorry. So I struggled for 20 years. I was on Suboxone for like 3.5. I then went back to school and spent the last 5 years working for Louisville Metro Public Health and Wellness in the syringe exchange program, doing outreach and QRT, following up on overdoses, and now I am the organizer for Vocal Kentucky. And we are a member-led grassroots organization that is fighting to end the war on drugs, mass incarceration, HIV, AIDS, and homelessness. And we do that by building power in poor and low-income people directly affected by those issues. I know that when I was struggling, I did not have a place to go and talk about this without the stigma that we've all talked about. It still follows me to this day. I'll have 13 years next month without any chaotic use. And I do want to put an ask out there to everybody to just really pay attention to the language that we use around substance use. There is all kinds of different things work for different people. But our language is so stigmatizing, and I carry that, sorry, I cuss a lot too. I carry that with me everywhere I go, still. And so the more we pay attention to the literal words that we use, the better we'll all be. I've heard people talk about a lot of things up here, and we need all of them. We need a menu of services so that when people need whatever it is, if it's housing, we should have housing. I can't ask somebody to stop using drugs that don't have somewhere to shit, shower, and shave and don't know where their next meal's coming from. It's not fair. It's not setting anybody up for success. And then when we do that, we just step back and go, God, I don't know why they couldn't make that work. And that's not how we work. So we need to set people up for success. We need to come away from the stigma and punishment that our current system is founded on. And we need to get to some harm reduction, housing, and care. Those things need to come first. We've got a lot of work to do, but it's so doable. And I've heard a lot of people talk about community, the relationships that we build with people. So every day, the people that I talk to about coming and being members of Vocal, it is my lived experience and my relationship building and trust that I have with them that gets them to show up. It's the reason that I have a voice. When I started having autonomy over the decisions in my life, and it wasn't somebody saying, this is your option, and you either take this or you take this. It's just, when it was me making these decisions, it's when my life started to change. So when we give people the tools to take care of themselves and the support needed to use those tools, then they do. People think that lots of people that use drugs don't want to take care of themselves or don't know how, and we as a system don't provide people with the tools to do that. So that's what I ask of this commission, is that we literally start providing people with ways to take care of themselves so that we don't feel like we have to do it for them, because that's not what sets people up for success. Let me make sure I'm not forgetting anything. I think all of that's good. I appreciate your all's time, and again, I get really nervous about that, but the people that have spoken, that have lived experience, thank you for using your voice. We need to stand up and speak more. It is hard, and it's uncomfortable, but it's what works. So, thank you.
Just wanted to make sure that we try to do 2 for 1. I'm not a former substance use person, but I grew up with it. Like many of you, my parents struggle with it. I grew up right across the bridge in Cincinnati, Ohio, and so the opioid crisis has always been an issue. I've seen people die from suicide, from AIDS, all the things that you're seeing. I've seen that all my life. So for me, it's full circle to come here and do this work. We were in Puerto Rico last week for a National Harm Reduction Convention, and so we missed the hazard forum, but I commend the commission for being intentional and going across our state. It's less about the lines that separate us and more about the issues that connect us. And this is a very important issue because these are not about people's personal failings. These are policy failings that continue to plague our whole state. And we have to have a statewide perspective. So I commend the commission for doing that. I think for Vocal, which means voices of community activists and leaders, for us, it's about making sure that the groups who aren't always at the table, who don't always get funding, who need to see some of this funding, and also making sure that people who work in harm reduction, who are saving lives, have benefits that match that. A lot of times they qualify for food stamps and Medicare because their organizations can't afford to pay them. So making sure that when folks are trying to get this funding from you, that they're including their staff. Because if I'm working to save lives, I need to make sure that my life and my family's life can be saved as well. We have committed to, as Vocal, to go across Kentucky with you to make sure that we're here and we're sharing, we're learning from you, that we can take this work and make sure that more people know about it. And I will be remiss if I didn't say, A lot of times when I come to these, I am often the only black person in the room, but black and brown people have been suffering from the opioid crisis for many, many years. And because of the stigma, because of the language, because of the accessibility, because of the lack of transportation, because of the lack of resources, that's why you don't see as many of them in the room as you do providers. So making sure you're being intentional, inclusive, like the commission is trying to do. If you see someone that's missing or an organization that's missing that you know that is on the ground serving the work, make sure that they know about it. I'm told that the portal is now open. There's a process. I've shared it on my social media. Make sure that you share that the portal is open so that we get more organic groups applying to make sure this funding touches every Kentuckian impacted by the opioid crisis. Again, thank you, and we're going to keep following you around state. All right.
Before our next speaker, I just want to briefly observe the time of the evening. It is 7:50. There are folks who are in charge of making sure this building gets cleaned up and took care of who are going to be here well after we leave. We're going to extend to 8:30. We want to leave about 10 minutes at the very end for the commission members to respond collectively to what's been heard this evening. And again, thank you all very much for the feedback you've given us thus far. It's been wonderful. Please.
Good afternoon. Good afternoon, Commission. My name is Jill Gay, and I currently work as the Chief Program Officer at an organization here in Northern Kentucky and Greater Cincinnati called the Family Nurturing Center. We don't provide substance abuse treatment, but what we do provide is the support and healing for families that have experienced a wide range of child trauma and adversity. We get the privilege every day to partner with children and parents who are in various stages of active addiction or recovery and healing from the very levels of sexual, physical abuse, exposure to domestic violence, and substance use that has driven them to have such large emotions that they need to numb those out with a substance. I wanted to share a little story with you to talk through how I started my week. And I started my week on Monday with a little guy who's 2. He was born exposed to opiates as well as severe domestic violence while in his mother's womb, and he was placed in foster care at 3 days of age. His foster parents and his biological parents worked very collaboratively together over the next 15 months for them to have consistent and regular visitation. His mother obtained sobriety and continued to work and reunified with this little guy when he was 15 months old. He stayed there in her home. Unfortunately, his father continued to be very violent in front of him, continued to struggle with his recovery. His mother eventually, due to the stressors of having to live that life on her own, of her own violence experience as a child, her own parents' history of substance use, and the trauma that caused for her, her inability to access resources such as fair housing, adequate child care that she felt safe leaving him with, led her to be so stressed and overwhelmed that when he was 21 months old, she relapsed. The last time that he saw his mother was last September when she was being arrested and taken from him, and he was waiting with strangers crying, waiting for his foster parent that he had been placed with to show up. I sat with him on Monday while he took animals in my therapy office and recreated those domestic violence experiences with a small penguin, a mommy and daddy penguin that represented his foster parents, a scary lion that represented his biological mom, and a rhino that was loud and violent with his mom that represented his dad. And I sat with him while we allowed him to work through that scenario over and over and over, saying, "I'm scared, they're big, I miss them," while his foster parents helped him to feel safe. When that session was over, I had the privilege to virtually connect with his biological mom, who I'm happy to say has regained sobriety, is a year sober, and continuing to work her plan to heal herself. And I sat with her while we developed a way in which she is going to reconnect with him and explain to him her love and her care and her apologies for his exposure to her addiction. That is not a service that is openly available to many children in our child welfare system. Many times, children are removed from parents in active addiction unnecessarily. There's the trauma of separation because there is no place for those children to stay with their parents. Their parents work their plan, they obtain recovery, but many times don't have the ability to see those children consistently because of hurt feelings by relatives who might have custody, barriers that our child welfare system encounters daily on staffing and funding in order to be able to support visitation programs. Children are scared when they don't know what happens to those parents. They worry for them and they take that burden on themselves. And it contributes to the mental health crisis that we are seeing for children with enormous rates of post-traumatic stress exposure. What I would encourage the Commission to consider are ways in which to support the healing of those children so that they are not likely to continue down the path of addiction themselves, but also to help families who are adults, parents who are struggling with active addiction and recovery to be able to heal the relationship with their children. So many times I've sat and had the absolute honor and privilege to be with a person in recovery, whether that be a mom or dad, while they navigated their recovery beautifully, but then were really struggling to repair the damage that they felt so much guilt and shame. And ultimately, at times, without the support to heal those relationships with their children, that guilt and shame can cause them to feel overwhelmed and relapse or go back to use. And that is something that we can do as a preventative nature to heal that family dynamic in the totality, is to ensure that those families have consistent contact with one another, have the tools to apologize for their part in their child's trauma, and to see each other consistently and heal. There are very solid evidence-based practices that shows when parents are able to accurately and consistently see their children, they are more likely to stay in recovery and heal. There are programs and evidence that shows when children removed from substance-using parents get to see their families, their rates of mental health concerns decrease. We have the opportunity to partner with our child welfare officials in Hamilton County, Ohio, where we provide a program that serves about 300 families a week in a variety of ways, but specifically ensuring that families who are impacted by removals get to consistently see their children in safe, productive ways to heal that relationship, even while they're still struggling with active addiction. We provide safety for them to see. That service and funding does not exist in our current state and is not accessible to families in our northern Kentucky area. And that is what I would encourage us not to forget. Substance use treatment is important. I have spent 50% of my professional 28 years as a licensed social worker providing substance use services, treating the trauma that either is caused by the addiction or predated the addiction. But I will tell you, one of the largest prevention work that I am privileged to be a part of is when we help that family heal together. And we don't forget that children as young as 2 need to be able to have that healing opportunity with their parents, whether they're in active addiction, in recovery, or relapsing. Thank you for your time.
Hi, I'm Joan Arlinghouse. I am a Casey's Law advocate here in the state of Kentucky. I wasn't planning to get up and speak, but after hearing everyone talk about the families, what's needed for the person seeking recovery, I am a family member in recovery. It was my family members that I've lived life with, and it's not an easy life. Fortunately, once you have access to treatment, once you have access to other people to help you, it can work. So my family members are in recovery now and doing very well. That happened after 10 years of no access to the correct information, not knowing what treatment was, because for years no one talked about it. So once I got to meet some of these other great people here in northern Kentucky, I really learned a lot about finding help. Those previous 10 years, I learned a lot about addiction just from living it with family members. And so I don't have a professional degree in social work or psychology, but I can tell you from the School of Hard Knocks, you learn a lot. So what I'd like to encourage people, is to support the families also. As part of all of your efforts to help the person finding recovery, if you can help their family, they can be a big support to that person. My family members will say, if they do not feel if we had not kind of forced them along the way, offered the right support, continued to support, they're not sure they'd be alive today. So family can really be a help in all of this crisis, the shortage of help we have available, the shortage of resources. If the family members can be educated on addiction and how they can help in a good way, how they can help in the right way, they can fill some of these gaps. Not everyone, because we know a lot of the bridges are burned and it takes years to repair those. But the families, for some, can be a great resource to help in the recovery process. And one way they can do that is through Casey's Law. And it's a great way for families to intervene. Friends can do it as well, but families can intervene a little earlier, before all these bridges are burned, before the children have been in foster care for years. So that's just something to consider, supporting the use of Casey's Law, and then also finding ways in all of your programming to help the family members be educated. And not just a little bit, not just a couple meetings, but addiction is hard, it's complicated, and the families need to understand it and also have realistic expectations of their loved ones and what to expect in their recovery, because it's a long, slow process. But it can happen, and I'm living it with families, so it can happen, and so there is hope. So when everybody know it works, and have hope. So.
My name is Victor Rivera, and I'm the CEO of Roaring Brook Recovery in Lexington, Kentucky. I'm also a person in recovery. By the grace of God, on December 18th, if I make it, I'll be celebrating 10 years clean and sober. 4 years ago, I started down a new career path, not a chosen career path, but something that I was kind of thrust into. I was thrust into it because I lost 3 friends in the span of less than a year to this opiate crisis. 3 fentanyl overdoses, not all using opiates. 1 who was using cocaine laced with fentanyl, and then 2 that were using IV heroin. And every time that we lost somebody, my group of friends and myself were challenged. What do we do? Do we sit back and watch? Do we just continue on and grieve? Or are we going to do something? And every time that we lost somebody, the first one, we got more involved, right? We started to work with nonprofits in the area who were doing really good work and started to raise money for them so that they could provide better care to people in the community. The second one, well, we doubled down. The third one, we did it again until finally, God showed me a different path. He opened a different door for me, and that was a challenge to open a treatment center that elevated the level of care available in our area. And that's what we are doing at Roaring Brook Recovery. Thank you to all the providers here, first off. This is a very challenging job that you all do every single day. The challenges that we face as providers, I think a lot of people have already mentioned it, but it's the only job that I've ever taken that we do work in hopes of being paid. And that is a challenge that we face, and I'm sure every provider in here faces every single day. For the people that work in recovery, our therapists, they have to go to school, and they're not reimbursed for the amount of time and expertise that they have. It is difficult for me as a provider and as a leader of an organization to sometimes have to pay, and we pay well, but to see people working as hard as they do, giving everything that they have and being paid at the rates that they're being paid. You guys have had great ideas, and I've heard a lot about Suboxone and medication-assisted treatment, and we are an MAT provider. It was something that, quite frankly, I was completely against. I come from an abstinence background, so opening up to that idea was very, very difficult for me. But my partner and I did the research and came to a conclusion that, you know, the research does point to the efficacy of medication-assisted treatment. But what we found was medication-assisted treatment and the efficacy of medication-assisted treatment improves when done in conjunction with treatment, with the psychotherapy, with the psychiatric component, with the case management, with the peer support, with all the wraparound services. So I challenge the providers, and if we're, you know, and the commission, when we're doing this, when we're investing in medication-assisted treatment, that we're looking at the entire continuum, that we're looking at not just giving money back to, you know, the companies that put us where we're at. That's really, at the end of the day, one of my biggest fears and one of my biggest frustrations. You know, the companies that put us in this place, that have caused those trends that you've seen, you know, are the ones that are paying for this, but at the same time are the ones that are going to reap the rewards as a result. Again, medication-assisted treatment, it's great when done in collaboration with the other services. Sober living, I completely agree. Expanding housing is a huge challenge, but that regulation component is very, very important. Making sure that sober living homes are doing it ethically. And that is a challenge for all areas. And I thank you all for allowing me to come up here and speak, you know, being that I'm not from Northern Kentucky, but we're here because we're passionate and we want to know what's going on, not only in our community, but in the surrounding communities. And we hope to be a partner. You know, we work with a lot of, not a lot, we work with some of the providers up here. Transportation, you know. Bobby got up here earlier. That's one of, you know, one of the people that I have an opportunity to work with on a daily basis. And the passion that he has is something that I see across my staff. And they're willing to get in their car and drive somebody to treatment because it's so important to strike while the iron is hot. And that's not something that we get reimbursed for. It's something that's put back on the providers to get them, you know, and get people into treatment. So again, thank you guys. Transportation is a huge issue. One of the things, and we've talked about all these problems, but one of the things that I want to challenge the commission on is data. You know, one of the only trends that we've seen or what we've talked about is the opioid death rates. That's one of the only things that we can measure. You know, outcomes is a huge challenge. How we measure outcomes across organizations needs to be standardized. And we need help. It is very expensive to create systems, to create processes, and we're not reimbursed well enough to, you know, to create those systems alone. So we have a ton of data silos that the MCOs hold. Let's open those up. Let's de-identify that data and let's give it to these people and researchers that are passionate about helping, and let's get some answers and figure out what really works, right? We do things a certain way at Roaring Brook. It's one pathway. It's not the only pathway. But if something is working better and we have evidence that it is, we will change. That's something that I challenge my staff every single day. Let's see what else is out there. And what we have found is that trauma-informed care, experiential therapy, neurofeedback, case management, peer support, the psychotherapy, group therapy, all these services when put together, and I can't measure exactly which one is working because we're doing them all at the same time, but it works. You know, I'm seeing people get better. And we want that to be available to everybody across the state. So thank you for your time.
Good evening. My name is Scott Hardcore, and I'm the current director of the Northern Kentucky Drug Strike Force. I had no intentions of speaking tonight. I would have been a little better dressed. But after listening to everybody, I did feel like it would be important for me to get up here. I've been in my current role as the director of the Strike Force for a little over a year now. Prior to that, I've done 22 years of law enforcement. During my tenure in law enforcement, from 2003 through 2009, I was assigned to the same drug unit as an investigator. Now having the unique opportunity to cycle back and actually see how drug trends have changed. As addiction counselors and specialists, you guys are facing an unprecedented problem, and thank you for everything that you do. This is not a problem that law enforcement can arrest ourselves out of. The drug trends that we're seeing now are way scarier than what we ever faced when I was an investigator. Van, I know, we worked together years ago, and I mean, you've seen it firsthand. You've lived through it with, all the different trends. I won't bore you all with some of the facts, but we were going back through a case file, a report that we did back in 2020. So just 2 years ago, we were buying an ounce of methamphetamine for $1,400. We can buy that same ounce of methamphetamine now for $350 every day of the week. The influx and availability of drugs it's amazing. We have a supply problem, so don't forget about law enforcement. They're just as important. The guys on the street stopping cars and all that, I know they get a bum rap, but they're doing the major part of trying to keep the supply down. My organization, we go after drug trafficking, the infrastructure, trying to bring it into our area, and without law enforcement, the guys stopping cars and doing the interdiction on the street, our problem would be even worse. I mean, we wouldn't be buying it for $350, we'd be getting it for $150, for an ounce. So it is important, but the last thing I will say, the infrastructure that we have in Northern Kentucky is amazing. Over the last year, I've worked with some great people, Northern Kentucky ASAP, Northern Kentucky Office of Drug Control Policy. They are doing amazing work. Life Learning Center, Alicia Webb Edgington is doing amazing things. My whole team has gone down and taken tours through her facility, and it's unbelievable. So thank you all. That's my whole purpose for getting up here, is I want to thank you guys for doing what you do on a daily basis.
So many programs now in place that we didn't have. We didn't, I mean, it's all evolved, and it was reactionary, and I think the ability now to take the information that we have and that we've gathered over these years and work with this commission to strengthen the continuum of care that we so desperately need, and all the families who are suffering so desperately need. We have things like the brand new Kentucky Judicial Commission on mental health, and are taking a really hard look at the court response to mental health and addiction. These things were not part of our vernacular 10 years ago. And I just want to say, in closing, that I want to thank everyone who is here, all who have worked on this, all who are passionate about this. We have a lot of work to do, but we've got a lot of really great experts and stakeholders in place, and I just couldn't be prouder of the work that we're doing, and I want to thank the Commission for all that you're doing. So, thank you.
We have time for one last speaker before we begin to wrap up from our end. Is there anybody else who would wish to come and speak? Going once, twice, 3 times. All right. Ms. Purdy, would you like to begin? Bring us home here this evening.
Me? Well, I'm honored to be here and to be in this part of the state. Coming from Louisville, I'm learning more and more about this. I am not a native Kentuckian. I've been in Kentucky for about 10 years, but I'm not immune to substance abuse. My father was an alcoholic. I have cousins who have been drug addicted themselves, so I'm very aware of the outcomes of substance abuse. So I am very honored to have been selected to be on this commission to help the people in my district, my area in Louisville. In particular, I work in West Louisville at Simmons College of Kentucky, which is the black historic HBCU in West Louisville. And West Louisville oftentimes gets left out because they think that the issue is not as prominent in West Louisville, but it is. It's a substance abuse that can be a poor problem, not necessarily a class problem. It also cuts across economic divide, so this is very important. My son is at a private school in Kentucky. I am the head of the prevention committee of this commission. So it's very important to me that we educate youth and students and people at private schools who have the access and the money to get the drugs if they want to. One of my goals is to help get the education into the schools, whether they're public or private, where people have access to the drugs. So I'm very passionate about making sure teenagers know about the issues that come with addiction. And I'm hopeful that hearing from you all that I will learn more and more about it and help my son, his generation of kids, and Louisville and West Louisville, those who are less than, who need help. So this information is very helpful to me to take back, and I'm very proud to learn more and be a part of this commission. So thank you all for being here. I'm very happy to talk to people and make sure they know the work of this commission. So thank you.
So I'm going to stand up so y'all can see me, and I'm short. So a couple of things I want to reflect on from what I heard this evening. One, we heard it at the beginning, we heard it at the end. We heard the word hope, right? That's so important. There is no darker place than the place without hope. You know that. Those of you who are brave enough to talk about your experiences in recovery and long-term recovery, thank you. Right? Those folks who need you as an example to bring light in when there isn't any hope, you all offer that. So thank you for sharing with us, and thank you for offering that hope. The providers here, you've got a lot of work to do on the systems, right? A lot of work to do to make systems work. Early intervention, those folks, low barrier shelter, making sure that when folks hit rock bottom, that there's somebody there to help. That's critical. How we set that system up with law enforcement, with hospital, with healthcare providers, and how we work together to deliver the services that are necessary, to deliver the support that's necessary. It's been said a lot of times this evening, right? Transportation, housing, food on the table, jobs, the support that folks need, behavioral health, MAT, all of those services that are necessary because addiction is a serious illness. And it is an illness. And to get away from stigma and understand that what's happening in here is an illness and a behavioral health issue that we need to treat that way. We don't tell somebody with cancer, well, you earned it, right? It was a moral failing on your part. No. People's brains are wired differently. People's experiences are different. It is incredibly important to think of it as an illness, and a long-term chronic illness, because that's what it is. Right? No shame. That's what it is. I'm going to take 1 second to brag on some folks, because CPS is here. I want to thank you, and I want to thank CPS. Child Protective Service workers, y'all, it's hard. Underpaid, under-resourced, right? Underappreciated. I talk about those folks that do that. You talk about walking in, right? Law enforcement, you all know, walking into a domestic violence situation, trying to walk into somebody's house and saying, we're gonna have to take your kids, right? That is dangerous work, it's hard work, and here's somebody that does it. So I call folks like that, I call CPS workers everyday heroes. Not the kind you read about in paper, or you hear about on television, right, or anything like that, because what they do, and you all know this in law enforcement, right? Everyday heroes. And making that difference in people's lives, I just want to say thank you. I want to say thank you for being brave enough to come up and talk and dream, because that's what we need to do together. Because the judge said it, we got to work together. What you all demonstrated in Northern Kentucky is that collaboration works, right? Working together works, talking together works. Thank you for leading that. That's what makes the difference. So you all coming here and talking to us, challenging us, that's exactly what we need, that's exactly what you need, and that's exactly what our communities need. So thank you all.
Being from northeastern Kentucky, you saw on that map, the very first one in Kentucky, my county is all real purple. I was a practicing pharmacist for 50 years behind the counter, and I've talked to people, loved people, prayed for them, they still die. It's a privilege to be on this commission and to help with this bill. And I do know one thing, that there's a lot of love when you get together like this. I know the people here have it in their heart to help others in humanity, or you wouldn't be here. And I thank you for that. And of course, my own personal life, spiritual, God put me where I'm at now. And the longer I serve in the assembly, the more humble I get. You can't be in health and family services without being a humble man or a lady. So I wanted to say a few things that I looked up once the worldwide sale of OxyContin 80 milligrams. And to tell you how big this problem really was, the sale worldwide, dollar-wise, was bigger than all the horse industry in Kentucky. So that had to be intentional. I'm sure you're going to talk a little bit about that. But by having 50 years behind the counter, I know, and being a pharmacist, I know how opioids hijack the brain. And I know it's not personal. This is personally. It's not recovery, it's recovering. You always be recovering. So I want to put that out there also. And when people run for public office, listen to them. You know, we had one presidential candidate that advocated for brain research. Anybody remember who it was? Jeff Bush. Addiction is a brain disease, and we need more research on it too. So thank you for the privilege of being here, and thank you all for attending tonight.
Good evening. Let me start out by apologizing. I had to leave the room. My wife texted me the first hour that I had a brother-in-law pass away this evening. And my mother's 84 and lives by herself in Fleming County. And I felt like I had to do a mental health check with her and make sure she was okay. So I want to apologize for taking so many texts and stepping out of the room. I love Northern Kentucky. I've loved this region for so long. As a law enforcement officer, I worked with people like Scott and Spike and Mark. And in this new career, I've got to work with so many of you. Such heroes up here in Northern Kentucky on this fight. I hold this community up all the time in national phone calls, in state phone calls of a place that's got it figured out. Not that you've eliminated all your problems, but man, you've come a long, long ways in that 10 years, Representative Moser, you're talking about. We've had great champions in the legislature. We've had great local champions here, and just great community folks like Charlotte and Joan and Kim that just take it to the streets every day. It's my honor to work with you over the years. Bonnie and St. Elizabeth doing amazing work over there. To have a hospital partner like St. Elizabeth, I hope you know what you have there. Nobody else in Kentucky's got a partner like that. A healthcare partner that really owns this problem and takes ownership of it. Because I've preached to some other big hospital systems. You need to look at what St. Elizabeth's doing. They haven't listened to me yet, but I still keep preaching. But I appreciate being with you tonight. I appreciate everybody that spoke, everybody who came out. It means so much. You know, and what I learned here tonight, Amanda, is problems in Northern Kentucky with transportation, the same problems we heard about in Pike. The problems we heard about with transitional living and sober living is not quite as sober as it should be. Heard the same thing in Hazard. So, yeah, the demographics are different, the regions are different, but a lot of these problems are just the same. And we're committed to do what we can to help alleviate some of those problems. So glad to be with you. Thank you very much.
Everything that you see up here this evening, and much of what you will see on the Opioid Commission's webpage is a reflection of a tremendous amount of dedicated work of some individuals I'd like to now recognize. Let me begin with one of our executive staff advisors, Ms. Allison Shavies. If you would, please stand. Mr. Scott Hornbuckle is our other executive staff advisor. These two individuals make sure that I keep my hair combed and my clothes on the way they're supposed to be on a daily basis, and don't forget my name. And last but not least, before I took this position, there was a gentleman out of the Attorney General's office who was the tip of the hour in terms of helping this commission be stood up. And that is the Deputy General Counsel for Attorney General Cameron, Mr. Blake Christopher. Please stand. At the beginning, when I was introducing myself to y'all, I talked about the perception I had of Northern Kentucky being an outsider to Kentucky. Everything that has been heard and discussed here this evening validates every bit of those impressions in terms of the degree to which you all have innovated, cooperated, and solved problems in a dynamic way that makes this region salt and light for the rest of the state, which desperately needs as much salt and light as it can get. Thank you for blazing a trail that the rest of us can look to model. This problem has a very specific history, and that history begins after World War II, when a small, very closely held family business began to operate and to become inventive with the way in which it produced pharmaceutical products. This company began with small over-the-counter home remedy type medications. And then it had a breakthrough with a medication called Valium. Those of y'all who are familiar with the Rolling Stones may know of a lyrical reference to Mother's Little Helper. That was Valium. Valium was sold and distributed internationally, but particularly heavily in the United States. I can remember my grandparents talking about needing a Valium whenever I got out of control and was giving them a hard time. It became a cliche joke to talk about needing the Valium. It became a part of the fundamental fabric of American conversation in terms of our response to stress and distress. Well, while Valium was being sold, this same company created a database which tracked every prescription issued in every region by every physician who was a prescriber. And this database aggregated data over the course of decades. This small family business is what we now know as Purdue Pharma. And in the mid-90s, the inheritors of that company themselves and those they assembled, which constituted a group of economic predators, sat down with a map of the United States to look at what the Valium prescribing habits had been in the decades before. And they made a strategic marketing plan for their newest substance, known as OxyContin. They looked to see where the people were the poorest, where workplace lifespan was shortest, where injury was greatest, and where pain was most acute. And beginning in East Kentucky, that company used the pain of our people's poverty as a pipeline to pump their poison into our blood. When we talk about stigma, there are many people who still yet believe that the opioid epidemic primarily impacts those who live within the margins of moral failure. The Judgment Day truth is that the people and the power centers which purposefully engineered this catastrophe are the ones who live within the margin of moral failure. And wherever this commission goes, that truth will be unapologetically and loudly articulated. $478 million may sound like a tremendous amount of money, but it is crumbs off of the table of rapacious gluttons. And for as bad as OxyContin was and continues to be in terms of its legacy, we have just started to see the unfolding of fentanyl. And right now, there is a Communist Party seated in Beijing which allows factories to run full tilt 24/7 producing fentanyl and fentanyl derivatives, which it turns around and sells to its business partners that we refer to as cartels in Mexico, that turn around and ship this poison in as many products as it can lace with it, right across a wide open border and the full eyes wide open view of our federal government. It is here, it is in our face, and we are much closer to the front end of this war than we are the end, despite being 25 years into it. If we do nothing else as a commission, we hope that we are able to not just seed change with the money that is given to us, but to declare that it is time that we wage war for our people instead of on our people. And so with that, thank you for your time, your presence, and may God bless all y'all. Thank you, Northern Kentucky.